I'm Dr. Rebecca Bowers, and in this video I will be discussing strain-counterstrain dysfunction and the classic method of treating, which is currently commonly referred to as counterstrain technique. Most osteopathic medical students are taught to find strain-counterstrain dysfunction by palpating for counterstrain points, and I will discuss these points as well as other palpable clues that inform the clinician that they are dealing with a strain-counterstrain dysfunction. First off, let's review a few concepts that are important to our understanding of strain-counterstrain dysfunctions, starting with reciprocal inhibition. Many muscles are neurologically paired with muscles spanning the opposite side of a joint in a reciprocal fashion, like the triceps and biceps brachii are. What this means is that when one muscle or group of muscles contracts, the reciprocally paired muscle on the other side will relax to allow for the joint to move in the direction the contracting muscle is pulling it. The contracting or shortening muscle is called the agonist, and the muscle on the other side that relaxes and lengthens is the antagonist. So when the triceps contracts, it's the agonist, but when the biceps contracts, the triceps is now the antagonist. In order for these muscle pairs to coordinate joint motion smoothly, the nervous system relies on afferent feedback from muscle spindle fibers to keep it informed of muscle tension on both sides of the joint. With strain-counterstrain dysfunction, there is a dysfunctional reset of tension allowed in a reciprocal muscle pair that causes one muscle to be kept shorter than usual and the opposite side muscle to be allowed more length than usual. There are multiple theories on exactly how this dysfunctional resetting of muscle spindle fiber tone occurs, but it does seem to be a combination of centrally mediated panic interfering with spinal cord mediated reciprocal inhibition processes, so that a muscle that is resting in a lengthened position, like the triceps is when the elbow is bent, develops a strain in it if the person is startled or panics and suddenly fires the muscle to contract it. At the same time, the antagonist, in this case the biceps, is rapidly lengthening under the influence of panic, which results in what we call the counterstrain. The effect of this is that the strained muscle allows more lengthening than normal, and the counterstrained muscle allows less lengthening than it should, and now has a counterstrain point in it. For example, say this young person taking a nap is suddenly startled awake and straightens up quickly. Their posterior back muscles, which had been elongated, are contracted in a panic and strained, while their antagonist muscles anteriorly are being forced to rapidly lengthen and could develop a counterstrain with an associated counterstrain point. Let's go back to the more simple example of a strained triceps and counterstrained biceps brachii pairing.
On exam, with a flexed elbow, we're going to find that it allows us to go into flexion, but when we take it passively into extension, it's not going to go that full distance. With a strain counterstrain dysfunction, it's going to be just a loss of a millimeter or two. And what I'm also going to notice is that as I flex it, it's going to just glide a little bit more easily. It's to fold around the point, like it just wants to go that way. The other thing that I might feel is when I'm in this flexed position, that there's almost like a line of tension on the other side, on that strain side that you might feel. And then when going into extension, right, the direction it doesn't want to go, when I get towards the end range of motion, I also tend to feel just a little subtle soft tissue tension in the back, like building up, like it just doesn't want me to bring it that direction. It's kind of like fighting me from the back aspect where these tissues go, no, 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 we're supposed to be longer than this, which is what happens with your strain counterstrain dysfunction. On the agonist side, you get these tissues thinking they're supposed to be longer, and on the antagonist side, you end up getting a counterstrain point in the muscle and these tissues thinking they're supposed to be shorter. After I notice that characteristic feel of how the joint is that's associated with strain counterstrain, then I can go look and find a counterstrain point.
While counterstrain points are usually tender to palpation, there are many reasons a person might have point tenderness. For example, a pimple, splinter, bruise, trigger point, Chapman point, etc. Visual inspection is sometimes warranted, but more often you can feel confident that a tender point is a counterstrain point when it has characteristic palpable findings and responds to treatment the way a counterstrain point should. So what do they feel like? Counterstrain points are just a few millimeters in diameter, and they feel like a crater with the very center more deep than the edges. Kind of like a sinkhole with the very center feeling tethered to deeper tissues, and there is no twisting around the crater like tends to occur with an inverted herniated fascial distortion. It is useful to be able to appreciate these objective findings as the subjective experience of tenderness to palpation, while most often present, is not always present clinically with counterstrain points. And these palpable findings can help in distinguishing between different types of dysfunctional point tenderness, as well as aid the clinician when setting up treatment for strain counterstrain dysfunction. For more on similarities and differences between other common dysfunctional points, watch my video entitled What's the Point? The steps for classical counterstrain treatment are: first, identify a counterstrain point. It should be tender to palpation at the point, but not so much in the surrounding tissues, should have the characteristic sinkhole feel, and should not refer pain elsewhere. Then stop pressing so hard, but keep your finger on the point so you can monitor the tissue texture abnormality. As with any procedure, make sure there are no contraindications. Then establish a pain scale. Tell the patient to think of the pain they felt when you were pushing on the point as 100% or $10 worth of pain or some such analogy. Now, position the patient into the treatment position, usually done passively, but if needed, you can ask the patient to help with this step. By monitoring the point, you will know when the optimal treatment position is achieved because the point no longer feels like a sinkhole, and when you briefly push on the point again, the patient will report a 70% or more reduction in the pain when you ask them. Now hold the position for 90 seconds, asking the patient to relax as much as they can. After which, you return the treated area to its anatomic neutral. It is very important that this step be done passively with the patient as relaxed as possible. If you are in a testing situation, it is also important that you keep your fingertip on the counterstrain point the entire time so that once the patient is passively returned to neutral, you can briefly push on the point to reassess what the pain level is at, hopefully 70% or better improvement. Many OMM written exams require rote memorization of counterstrain treatment positions, but in real life, the objective palpatory tissue texture abnormalities can guide the practitioner to the correct treatment position. When the patient is being moved towards the correct treatment position, you will feel the sinkhole filling in so that once you reach the ideal treatment position, the point now feels level with the surrounding tissues, and you will feel like you are pulling against a tight sheet of connective tissue on the opposite side. Let's watch a video of a counterstrain point being treated with classical counterstrain.
To treat a counterstrain point with classical counterstrain, we're going to say that he has a counterstrain point in his biceps, right about here. So you find the point, push on it, should have the palpable characteristics that are described. Does it hurt when I push?
Yes.
Okay. So that pain that you feel now when I'm pushing on it, we're going to say is like $100 worth of pain. Okay? All right. So you establish your pain scale. Then you're going to put it in the treatment position, which for many points is you just shorten around the point. Some are a little bit tricky. Luckily, there's charts for those. But for this one, we're going to flex the elbow up. And it's not just good enough that I flex it. What I want to feel is adjusting wrist and the form and everything is ideally when I have it in the right position of flexion, I will feel like I am pulling against a line on this other side that lets me know, yeah, I'm in that position. The other thing is my finger that is monitoring the point but not still pushing on it is going to feel like that sinkhole has evened out. It's like filled in. And then I'm going to push on the point and say, all right, how much of the $100 worth of pain is still there?
Zero.
Zero. Okay, so we want to have at least a 70% reduction of the pain. I'd hold it there 90 seconds. We're going to imagine that much time went by. And then slowly and passively, so as relaxed as you can be without falling over, I'm going to return the part that I'm working into anatomical neutral. So I don't have to have them stand up or anything. I just need this part to be in it. And then I'm going to push on it again and see what the pain would be, but we didn't really treat it since we didn't have the 90 seconds. Now the other thing then is ideally now I should have resolution of that flexion elbow dysfunction that was going on. So if I retest, I shouldn't feel that gliding sensation when I flex him, and when I go into extension, I should feel full extension, and I shouldn't get that sense of the tissues being too bunched up on that extended side.
In the clinical setting, you can often figure out where a counterstrain point is based on history and physical exam, and usually the treatment position is achieved by bending the soft tissues around the point. I have discussed and demonstrated classical counterstrain technique in this video, as it is what is taught at the osteopathy schools and tested on boards, but I treat most counterstrain points with my own particular method of neuroocular release for counterstrain. It has many advantages to classical counterstrain, one of the most impressive being that it only takes a few seconds. Make sure to watch my other video on neuroocular release counterstrain method. As with any medical procedure, one must consider the known contraindications as well as the clinical scenario of their unique patient's case. These are the potential complications for doing counterstrain in a reasonably competent manner. For further reading, Lawrence Jones first described and developed the strain counterstrain model and classic treatment approach, and his Jones Strain Counterstrain book is essential reading on the topic. Paul Rennie also has written a great book called Counterstrain and Exercise, but it is out of print and difficult to find. Harmon Meyer's Clinical Application of Counterstrain is a clinically useful book, but the author combines counterstrain points and trigger point information in a way that can cause confusion between the two. For concise charts listing locations of specific counterstrain points and their treatment positions, the Nicholas Brothers Atlas of Osteopathic Techniques is a great book. I have made this video as a resource for other physicians and bodyworkers. Do not attempt to perform any manual techniques unless you are a physician or bodyworker or a student under proper supervision.